We're called meeting to order of the June 9th Monroe County Health Board of Health meeting. We are going to do some introductions first. Let me introduce people on. Oh, look, we have pictures now. I love it. Okay. Yeah. Mark Norrell, you'll give us a wave.
Good afternoon, everybody. I'm Mark Norrell. I teach healthcare management policy at Indiana University. I've been there teaching for 10 years. Prior to that, I was working for hospitals and health systems as executives within those systems for 25 years before that.
George Hageman, you want to give us a wave?
Hi, I'm George Hageman. I'm a retiree from IU from the microbiology group of the biology department. And I've been a health board member since, I don't know when. It's been quite a while. I think more than 20 years.
Ashley Crainer.
Hi, everybody. My name is Ashley Crainer, and I'm currently Chief Deputy of the Monroe County Recorder's Office. And I got my master's at IU in public health and have been serving on the board for, I think, 12 years or so.
So in person at the meeting here is Dr. Wren.
Hi, I'm Robert Wren, a retired obstetrician gynecologist. I've been on the board for 4 or 5 years, and I appreciate what the board does for the county.
Steve Pritchard.
Hi, I'm Steve Pritchard. I'm a retired dentist, retired clinical dentistry. I still do dental exam, license examining, and I do that all over the country. Been on the board for many years, not as long as Dr. Kalukian or Dr. Hageman, but long time. Pleasure to be here.
Kay Leach.
Hi, I'm Kay Leach. I'm a retired registered nurse, and I also have a master's in public health.
And I'm Carol Talukian. I'm a retired pediatrician. I'm president of the board at this moment. Okay, and we have one other, oh, no, and Penny, and go ahead.
I'm the administrator at the health department, but we just, for the record, have to know which board members are here and how they're joining.
We want to introduce everyone, and Dr. Sharp.
Dr. Sharp, the health officer.
And we need to introduce Lori Kelly, who is our new hire for Penny's replacement. Not that Penny can be replaced, but
How big are her shoes?
yeah, big shoes. You want to say hello, Kelly? Lori.
Hello, my name is Lori Kelly, and I'm really looking forward to entering into this new role. So thank you.
Thanks for joining us today.
Of course.
We will see you on Monday.
I was going to ask.
She starts
You start
officially
Monday. Oh, great. And wouldn't it? And how long will you guys overlap then?
We'll have 5 weeks together. My last day is July 15th.
Okay. You'll be sure we sneak another board meeting in before you.
We've got one the day before I go.
Is our next one July 14th? Okay. 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 So do we have anybody who
Do you want me
to comment, Michelle?
Oh, do you want me to go ahead and introduce staff, the new staff? Or do you want to wait?
Why don't you go introduce new staff?
Okay,
Yeah,
because then
that'd be good, just so they don't have to hang out forever.
Yeah, so we've had several new hires for various positions. And so I wanted to take a moment just to introduce the staff that have joined us over the past month or so. So Matthew Allison is one of our new DIS, our disease intervention specialists, and he is an IU grad. And if I mess up any of your information for any of you all, I might mix you up, you know. So he majored in epidemiology, and so a great fit. And he was working at the Porter County Health Department and came with high recommendations from them. And so we are thrilled. He has been with us, what now, a month and a half or so?
1 month actually today.
All right, great. So thank you, Matthew. We wanted you to meet everybody.
Awesome.
And then we have Susan Callahan, who is our LPN. You know, we had trouble finding that, and sometimes good things come to those who wait. So she was in home health, but had worked in gynecology and women's health before, and decided she wanted to come home to women's health. So we're glad to have her, and she has been here, what, 3 weeks now?
Yep.
3 weeks. So welcome to you, Susan.
Thank you. Happy to be here.
Glad to have her. And then Joe Branham is our new school liaison, and Joe has an associate's in nursing. He has, we won't hold this Purdue degree against you, Joe,
Well,
but he has, he has his bachelor's in healthcare administration, and he's working on a master's in public health, I believe. If I didn't, he's shaking his head yes, so I did not mess that up. And he has taken on the role of our school liaison. Emily's last day in that role was Friday, and so they were together last week and able to work together. Emily, luckily, started out as our preparedness assistant, and then when the school liaison came up and she had graduated, she filled that role. But in working through COVID with us, she decided she was going back to nursing. She was going to nursing school. So she is going to return in July back into that part-time assistant position. So we really won't be losing her. So we're glad about that. So welcome, Joe.
You're welcome.
Thank you.
And then by no means least, but the last on here today is Alyssa. And I'm not sure, Michelle, that may be somebody that I didn't. Is Alyssa Delgado signed in?
Not present.
Okay, so she might be having some trouble finding it. So Alyssa is an IU grad in environmental health, and she just started with us this week. And she is filling that environmental health specialist role, that temporary position that we have. And she actually finished her internship in Brown County and came highly recommended from Brown County. So we are thrilled to be having all of these positions filled, and we are wrapping up some interviews for part-time positions and hope to have all these vacancies taken care of in the next few weeks.
That's a lot of work.
Yeah, yeah. So
And
very good.
Sounds some wonderful people.
Yes.
Okay, and now we'll do public comment. Michelle, is there anybody who wants to do public comment?
There are no hands raised.
Okay, well, we'll put that away for now. So the next order of business is approval of the May 5th meetings.
Although I think we might not have given them enough time. There is one person that wants to comment.
Okay, and then keep in mind, there's a 3-minute limit. Do we have the timer, Michelle?
Yes.
Okay, so, and it makes, you want to tell them the sound that makes it 2.5 minutes?
One moment.
Can you hear me? Can you hear me?
Yes. Okay.
You
So that's okay, so that's the sound. It's made it 2.5 minutes. So we have three. We have.
Okay.
3
So
minutes. To speak. Who is this? Is this?
My name's Andrea. You can hear me?
Yeah, Andrea, introduce yourself with your full name, please.
Andrea Ford.
Are you associated with someone, or are you just or just?
I'm
Just public?
I'm just a resident, Indiana resident.
Okay, great. Thanks for joining us.
Thank you for having me. So I've heard some discussion on the public health and the governor meeting on centralization or the merging of county health departments in different areas of the state. Because of the differences in county to county needs regarding response to public health issues, how can we ensure that local control remains intact? If this is something that is being considered, how will counties such as like Greene or Lawrence or Brown County surrounding Monroe, for example, be able to exert accountability or voice concerns in a meaningful way when we don't have any control over who's elected in Monroe County? So if there's an umbrella and one county, making decisions for everybody, how can surrounding counties exert their concerns?
So we can certainly share that with the governor's commission. I think that that's what you're referencing is those discussions that they are having. But those comments cannot actually go directly to them as well. So I'll tell you what, if you send me an email and it's pcaudle@co.monroe.in.us with your information, and you can even say what you're concerned about, and I will get you to the right people that you can share that with directly to the committee.
Can you say how far discussions are being are at this point in the process? And if there are counties that are already on board with this conversion or merging of public health?
Yeah, they've not made any decisions at this time. They are just getting information and having discussions. And certainly nothing has indicated to us as local health departments that that's what they're looking at. There's always discussions about what they refer to as kind of regionalization.
Centralization, maybe.
Yeah, it just depends on how broad it is, right? So those discussions come up occasionally, but it would need those concerns. I appreciate you coming today to share the concerns, but those going to the State Department of Health and the commission directly would be the right place to put them.
Okay, thank you.
Anybody on this commission?
Oh, yeah.
So-
And like I said, there's not been anything to us to say that that's where they're moving. It's just right now the commission has been taking a lot of discussion, hearing a lot of information, and just really having a lot of discussions.
Yeah, so
And that's something a lot.
This sounds like public comment. That'd be really good.
Yes.
Thanks for sharing that with us, Andrea.
Thank you. Well, thank you for the information. I will definitely check in with the state, and I'll send you an email so that whatever information you have, you can send to me.
I will get you the right person to contact.
Great. Okay. Thank you so much.
Okay. Anybody else, Michelle?
Now there are no hands.
Okay, great. Now we will entertain, any changes or corrections to the May 5th meeting minutes? Hearing none, I'll entertain a motion to accept them as written.
So moved.
Steve Pritchard, I need a second.
Second.
Bob Wren. Okay, great. So we need to do a roll call,
You
don't
need
we?
to do roll call.
Okay. Dr. Wren?
Pardon?
We're voting for accepting the minutes as written.
Oh, yes, yes.
Yeah.
Pritchard,
Look at the
Yes.
screen.
Leach,
Yes.
Laura,
Yes.
Trainer,
Yes. Oh, no, I abstain. I wasn't there. Sorry.
Hageman,
Yes.
and I also vote yes. Okay, the minutes are accepted. We have public health reports now. Is anybody that need to go first?
No, I see Graham is on. Michelle, you might look for Kirk White. But Graham is on, so we
Okay,
can
great.
hear from Graham.
Can we see
Hey,
Graham?
everybody. Sorry, I'm offline. Can you hear me?
Yes, we can hear you, Graham. We can't see, but
driving.
we can hear you.
Yeah, driving back from IUPUI right now. I'm not driving, so this is safe.
Oh, good.
I don't think Kirk could make it. He just got back from vacation today as well. So I don't think I have a lot of updates. We're kind of in summer mode in our response at IU. We have a lot of summer programs and camps going on, so that's kind of our focus. Our PCR labs in Bloomington and ND have been temporarily closed, but we're keeping those in place so we can use them or use them as needed. And I assume we'll probably need them in the fall. So students can still get tested at the Student Health Center through our arrangement with IU Health. And then we still have antigen tests available on campus as well. Contact tracing has been slightly modified to be a little bit more automated, but we're following up on cases that report a high number of close contacts, or if we think we have linked transmissions from IU events or IU housing and things like that. We're still meeting daily with our case review and outbreak investigation team. We should have wastewater testing capabilities the next month or so. We're hoping to partner with CBU to provide some of that testing and maybe provide more frequent testing and a shorter turnaround time, which I think would really benefit all of us in the community. So we're excited to have Dr. Justin Greaves coming from Notre Dame to IU Bloomington School of Public Health. They'll have a lab and innovation center at 10th and the Bypass. In terms of trends, we've had a little bit of a wave towards the end of the semester, like we have nationally and regionally. And probably towards the end of the school year, then really the couple weeks after, even maybe even a higher caseload. That's dropped. It's been about half of that. I don't have the Bloomington specific numbers in front of me, but from a system level across all campuses, I've been flat between 13 to 15 cases per day on a 7-day average for 2 weeks now. It kind of seems like the state may have flattened out a little bit too. Still a high level of transmission, obviously a lot that's being missed without home tests being in the state numbers, but we're continuing to watch that as well. And then as of right now, our current policies will remain for the fall in terms of either vaccine or exemption reporting for new students. And that's kind of where we are right now.
Sounds good. Anybody have any questions for Graham? Thanks for joining us, Graham.
Thank
So
you.
next we have the Public Health Clinic, Lori Terrell.
Yeah, so we have
There you
been
are.
steadily, hello, we have been steadily giving, of course, the boosters. So we've seen that steady for 50 and above, mostly in that category. We are starting to see some boostering for 5 to 11. We are ready and have put an order in pending approval for the under 5 category that's supposed to come up here on the 18th or 19th of June. So we will be prepared to be able to vaccinate the 6 month to 4-year category if that is approved and ready to go through. We have changes coming to our hours starting in July, which will have some extension. So we will be open on Mondays until 6 p.m. And then we will have the second Saturday of every month where we'll be open to provide services from 8 to 11. So kind of increasing to kind of get outside of work hours for some opportunity there. Our school clinics kind of wrapped up with the end of school year, but we're already planning for some July events, as well as getting back into our fall rotation clinic with the hopes of being able to offer not only COVID in those clinics, but also working to do some catch up for those kiddos who need vaccinated so we can catch them in that first few weeks of school and hope that maybe we can get them sooner in the year versus school having to risk for expulsions and things like that if they don't get those vaccinated. So we have Zara working hard on getting that aspect ready to go. We have changes to the lead surveillance and case management and risk assessment coming here in July. So we are getting everything in order for that. That will mean any lab test 3.5 to 5 will now fall into the risk assessment. So looking to do education, doing the screeners with the families, and any case 5 and above will go into case management. That's a new state standard coming. We've been doing that here in Monroe County for a long time for the case management for the 5 and above. So it's just adding in that 3.5 to 5, the education, and working with the local providers to make sure they're aware of that education on their end, since that's a little bit different in the workflow for those aspects. We have some outreach clinics. So we have an outreach clinic this Saturday. We have about 60 people signed up. That's a full wellness clinic. So we'll be doing A1Cs, blood pressure screens, cholesterol screens, as well as offering COVID vaccines into that group. We have the Futures Planning Clinic scheduled with Monroe County Health Department, and that is on the 14th from 9 to 11. And then on June 25th, we have at the Housing Authority, we're doing a family fun night. So we'll be doing COVID testing, looking at immunization records, to see who may be needing immunizations and having education and talk to them about getting those scheduled.
One thing we talked about last time is the website, the state website didn't have the clinic on it.
Yes,
Has
and
that been
so,
fixed?
well, not yet, but it's in the works. So what we found out happened, because we were on there. So what happened was when we started making appointments locally and not using Zotec, which is the state's scheduling system, then they removed us from the map by accident instead of just removing that piece. And so we've submitted our hours and all of that. So there's a process for getting all that back on. And in the meantime, we're making sure, like at the commissioners meeting and where we have media there, that we're making sure that they know that if they need an appointment, they can call directly to the public health clinic, and the numbers 353-3244. Did I get it right, Lori?
You did.
All right, and they can make an appointment. So those July hours should all be up. I'm checking it every few days, but I have a feeling that they may not put it up until we get near those changes, so that they only have to put it in once instead of putting it in and then turning around and changing it yet again. So that is resolved. And then the information about the lead, and I kind of had that to give you that update a little bit later as well.
Okay, we
So,
said, okay.
yeah.
Oh, great, thank you. Anything else for Lori? Any questions? Thanks for being here, Lori. Okay, next we have public health emergency preparedness. Christina.
Yeah, Christina, come on up.
Christina.
Stand.
Yeah, you got folks inside.
So my name is Christina Kim. I'm public health coordinator. I wanted to come face to face because it felt like one step closer to being back to normal. So thank you for letting me be here in person. I want to talk a little bit about some test kits that we received from IDOH. We were given the opportunity to distribute home test kits. So we received 20,000 kits. 10,000 went to the Monroe County Public Health Clinic, and they have already started distributing those to identified agencies, organizations that we deem that would be where those would be useful and that would be needy for them. We have started just 2 days ago distribution through some of our local programs here within the health department. And then once they kind of wind down on their distribution to those agencies, we'll kind of circle back around and see who is still left. And we have some ideas that we are working on right now that see, maybe there's another round that may need to go to some other agencies. So we're just working together on that. Right now, it's 2 tests per person. If you have a family, say of 10, you're able to get 2 tests for each person there. So that's going to be exciting, and it's just another opportunity for people to get tested since our test site is, has been, our community test site is no longer. One of the big things that we've been working on in conjunction with a partner that we brought on is our hot wash after action report and improvement plan. We contracted with Resilient Strategies and specifically Jason Gates, and they are very experienced in doing after action reports, exercises and so forth. Actually, our district emergency preparedness and planning coalition, they use them. They did their after action report using Resilient Strategies. So you probably or should have received a survey. We sent out 1,400 surveys to all the community partners and individuals that we, not necessarily public at this point, but individuals that we worked with through schools and preschools and churches, homeless agencies, leadership, and IU, the boards, and just so forth. So we had 131 surveys were completed. And so Penny's always like, that's, I'm wanting we sent out 1,400, I'm wanting 1,400 back. But to be realistic, so that was a pretty good response in that the fact that it wasn't just most of them weren't just marking the answers, they were giving the comments, and that's where you get a lot of that information. And so we just were able to sit with Jason and go through the draft final report. There's a lot of great information in there. So my grant cycle is closing June 30th, and so the next grant cycle, I will be taking those things that we identified as improvements and working on them. So those are basically the next set of the deliverables. So as I said, 131 surveys completed. There were originally 12 sessions, like workshops where people could give feedback. We narrowed that down to 4 just because most people, I guess, felt like they had enough opportunity to give feedback through that survey. We will definitely share that after action report and improvement plan once we have that. That will be available. And I won't take time to go through. We'll do that next time. What some of the findings. And the last thing I would just encourage encourage you all, if you have not been to the Monroe County History Museum in some time, there's currently a COVID exhibit there in the main room. If you walk in, it's on the left. There's some familiar faces from this room that you would see. They have some quotes on the wall. There's a short video there, but there's also a video that you can access through their website, or it's a YouTube video. It's about 40 minutes, and it's just talking about, it's the voices of some of the responders during COVID. And so I encourage you to watch that online and to go there and just, it was interesting because they interviewed people during the height of it. So we're kind of at a different point now, and it's interesting to look back. And I think it was really well done. Any questions?
I did have one. Let's go. Oh, yeah. So in terms of the COVID tests, I'm assuming you've gotten some of that to the homeless shelters, and
yeah,
so I would think that's probably a really high risk population,
right?
Hard to access.
So in partnership with the public health clinic, they kind of jumped on that, and they've been giving to all kinds of places. We have a list that we're sharing, so we can see where they've been giving out. And so, if you have ideas, we have a pretty comprehensive list, but we're certainly open to ideas. Information is getting ready to go out to the media as well. And so agencies or organizations that maybe haven't been or contacted yet, but if they're interested, they'll be able to contact me and we can discuss that and, see how we can get them tested. Yeah. So they will be able to come into the vital records. The public would be able to come in and pick those up as well as a public site.
Any other questions? Thanks for
Thank
coming.
you.
Thanks for coming. It's good to see your face.
Yeah, yours too. All of you.
Thanks, Christine.
Okay, and I think Penny, you're next.
Yeah, so we've already introduced the staff. The other things that I would note is that code review assignments have been done. So we're looking at our fees. We are looking at campgrounds and mobile home parks. We kind of touched on this, I think, at the last meeting. And then the septic revision. So House Enrollment Act 1245, there's still some, I'm going to say, discussion around what pieces, it goes into effect July 1. But there is a little bit of a portion of that that's a reprieve for a year that gives local health departments in the state a chance to revise codes over the next year. There's a little discussion on, does that mean that our code still trumps this new law, which I don't think it does, except unless somebody doesn't challenge it. So we're still working through that with legal. So far, legal has said we'll go down line by line pretty much and see if we need to have our local code or if we're better off just saying we're going to follow the new state code and the state law and not try to match everything up, which is what we do for lots of other things. Swimming pools, for example, we follow the state code. That's, it's pretty simple. So we'll be working on those things. Those assignments have been made. They've changed some things around home-based vendors. That won't mean a lot of changes for us in terms of codes, but it will mean that we have to, all the home-based vendors are supposed to inform us, or essentially, if you will, register that they're a home-based vendor with us. So we'll have to keep that running list, things like that. So we're incorporating some of those legal changes into what we're doing. And then, of course, the CHIP, the Community Health Improvement Plan, we're working on that. The staff have scheduled a kickoff to bring those teams together on July 14th to really start working on those priorities that were selected during that process. So those are the primary additions to kind of what I had shared already. And then COVID notes, and Graham kind of talked about this a little bit. Transmission is still elevated, it's still high. However, our numbers are remaining pretty stable. We're not seeing a lot of change one way or the other, just a little bit of fluctuation. Hospital numbers, we have seen some increases in hospitalizations, especially in the older population, although we've seen some young people and middle-aged people in the hospital as well, but our deaths are not going up. So if there's wood, if I can knock on some wood to keep that there. And so far, the hospital numbers overall have been pretty stable. So we've seen some increases, but they're still on that low end so far. CDC community levels, I don't expect us to move out of low, but those go up on Thursday evening. So they're going up sometime when we're done. They're usually not posted before. And then as of Wednesday on the state dashboard, so we were averaging 29 cases over a 7-day average. That was down by 2 a little bit. And so that number is really running right around those low 30s. So when I talk about it being stable and just little fluctuations, that's what we're seeing. Reinfections had dropped. On Monday, they were at 9.3%, and Wednesday, they were up to 13%. So that was, again, some fluctuation, but they had been kind of hovering around that 10 or 11 mark. 65 cases per 10,000 on Wednesday. And again, we're kind of seeing it in that 60, 70 range. Tests were down a little bit at 193. And we've seen in the last month, I went back and the number of tests kind of, we look at that now almost every other day, right? Monday, Wednesday, Friday. It's ranged from 170 to 260. And so earlier in the month, it was 260 down. The lowest has been 170. It was 193 on Wednesday. So we're seeing some of that, but we're still seeing enough in those that those are what's reported that we know that we have a high level of transmission based on the positivity for those. So again, things are kind of stable, but I try to tell people our community level is low because we're not seeing a lot of severe disease. Doesn't mean that we don't have a lot of transmission going on, because we do. The good news is it seems to be milder as opposed to more severe. So we'll continue to watch that, all the data. We're watching the wastewater data as well. Again, we can't draw strong conclusions at this time, but it's very interesting to see kind of what happens, right, around the events, graduation, little 5, those kinds of things. Then you kind of see spikes come, some spikes maybe with increased in hospitalizations, but overall the numbers have been coming down. So right now it's just kind of extra information to have, no final conclusions to draw from that. Vaccinations are still available. We talked about that. And our vaccination rate right now, I looked at that, between 54 and 72% are fully vaccinated of those that are eligible. It kind of varies by zip code, right? And then if you look at it by age, 50 and over are running 71 to 82% are fully vaccinated of those who are 50 and over. The lowest group at 29% is our 18 and 19-year-olds. So kind of those are the places that we can maybe try to do some extra work. But interesting to kind of watch the dashboard and see what changes come up, and we are continuing to watch that and see where we are. But we would like numbers to continue to come back down, but for the moment I will be somewhat satisfied that they're just not going up drastically. So kind of where we are.
Did I have any questions for Penny? Okay, so you want to talk about lead?
Yes, just a little, because the old business, we had talked about that. So in 2021, there were 5 lead cases that tested under 10 but above 5. So in between that 5, the blood lead level being between 5 and 10. So they required some nurse intervention, including parent education and provider contact. The Indiana Department of Health anticipates that we could see as many as 24 cases from July of 22 through June of 2024. with these new guidelines that are in place. So they are using ARPA funds, some of the recovery funds, to fund some public health programs. So we did get awarded some money for our lead program. So the extra work that it will take for our nurses, we plan on doing an educational campaign around lead over those 2 years as well. So we'll use those monies well. The grant award notice has come, but all the paperwork is being processed at this time.
Any other questions about lead? We had a little talk about it last time.
Yeah, we talked quite a bit about
Yeah.
that.
Yeah.
So,
Yeah.
Yeah, that was just kind of left lingering, so I wanted to.
A dangling participle.
Mhm.
All right. And we talked about the vaccination site map already.
Yes. And then just another follow-up, this isn't on here. We did get the letter for Indiana Recovery Alliance. I did go and talk with the commissioners and legal. The opioid money that, from the settlement is what seems to be probably a very good use for those kinds of funds. And Indiana Recovery Alliance has also been informed to look and talk with the city as well. So they're hoping that maybe as a unit come together and be able to assist them. But there's some work being done, some discussions being done on that. No decisions made, as far as I'm aware at this time, kind of turned that over, but they have received that letter that Dr. Talukian and Dr. Sharp signed off on. So I wasn't sure if I had given that update that had actually went out, and I'm like, well, I need to add that, so.
That's
Yeah.
good. Okay. Any other business before we start talking about the budget? Anything? Anybody else have anything you want to bring up? All right, budget. We love the budget.
Well, the hope for this.
We have a piece of paper here that has some information about the budget. It wasn't that stuff that
It's kind of at the back of the
Kendra
updates.
just gave us a while ago.
So, and I'll just kind of go through the three main budgets that we take before council to the budget hearings now are the health fund, and that's our primary department fund. And then the two tobacco settlement funds, the local health maintenance fund and the Indiana Local Health Department trust account. So those are the three that I've kind of addressed in here, and really just want your feedback tonight as Jamie and Lori and I start putting together that budget for you to vote on in July, kind of where you want us to maybe think about things outside of the normal things. So the first thing that I just wanted to say, I know when we met earlier that the first 2 quarters of this year, our revenue appeared to be up quite a bit. March came down some, but we ended that first quarter about $3,000 over our revenue for the same period of time in 2021. But when we look at it at the end of May, we're actually down from then by just under $7,000. So we'll continue to watch that and report that back to you. It's always nice to look at things at the end of June at that mid-year point to kind of see where you are. We have seasonal pools that will come up. The Taste of Bloomington canceling, that's temporary permits that we don't have. So those kinds of things will affect us as well.
So the numbers you're quoting are just fee-based numbers.
Yes.
Okay.
Yeah. Yes.
And we haven't looked at fees for a while.
Right.
So, and we're going to do that.
Yes.
Okay.
Yeah. And we'll look, and again, we'll kind of see where we are at the end of June and try to do an assessment on what's changed, right? Like, is it coming from food? Did that drop? Was it in foods or was it in wastewater or vital records? One thing in 2021, remember, we did a lot of death certificates. And so that change could in fact be the difference between the number of death certificates we issued in the first 5 months of 2021 versus 2022.
Right.
So it could,
That's the good news.
yeah, yes,
Yeah,
that
yeah.
I would hope that would be
Less money is good.
the difference. Yeah, that's a good,
It's a good thing.
yeah.
It's a good thing.
Yeah.
Okay.
Well, it was kind of like when we changed some processes to reduce, to be more proactive and get people licensed. So we had fewer people late, right? But that also meant for us, we didn't get late fees, right? But that's a good thing because we don't want to have the work
Right.
with collecting those. But
Right.
in the revenue world, it looks like you brought in less money. So.
Now, we had agreed to review fees I think it's every 2 years.
Yeah, and then-
But of course, the pandemic came
Yes.
along and it wouldn't have been appropriate to raise fees during a time where nobody was making any money. So
Yeah.
Yes, in
Yeah.
2020, we started reviewing fees. Fees were up in 2020. And the campgrounds, we started in 2020. And then it all got
Hit the fan, yeah.
halted. Yeah. And so it has been a while since we've done
Okay.
those. Yeah.
So we can do that after the budget though, right?
Yes,
So maybe
absolutely.
schedule that for August or something.
Mhm.
Start looking at those, or if that fits.
Yeah,
into-
the staff has already been assigned, so they should be, I would say in August, hopefully they'll have some feedback to bring you in terms of what they think would make sense, and
Okay.
you can have some discussions about that. And then usually it could be voted on earlier, but generally speaking, we voted on those at the, in your fall meeting, which is usually October, to go into effect in January. But I will say with fees, it would be really nice to have a decision made, even if they go in January into effect, the earlier people know that, the better.
Right.
So.
I think if we
Yeah,
can
that's
do
no
it in
problem.
August,
Yeah.
that should work.
Yeah.
I think we can do that. That's not that onerous, once they get the information.
Yeah,
So-
so where Jamie put together, we've kind of just started looking at kind of those last few years. We always try to go back like 3 years and look what we've spent and what we've appropriated to try to look at what kinds of supplies and services, where we at, what do we need? But what I tried to highlight here were what are the real things that you all need to kind of think about, because we can say, hey, we need more in supplies or more in training, and we can tell you that, right? But the public health clinic, for example, we have our contract with them that's annual. Last year, we increased that by 2%. Do you want to try to put in some sort of an annual increase that they get every year? That might be an easy way to do it. But
I have a question.
yes.
And if I might, from a process standpoint, we do have a lot of, quite a few, several external partners, that we sort of go through this on a regular basis and ask, should we increase it or not? And there's not a whole lot of context in terms of, what are they doing that might require increase? So from a process standpoint, and I'm glad Lori Kelly is with us right now, maybe we should sort of take the approach every year that we notify each of these entities and say, what are your, I don't know if we want to say your requests, but what are your priorities, and what areas do you see a shortage of funding, and use that as a way to frame these questions. And for example, we've got this, it's the birthing center tandem, the prenatal, right? We don't know much about that at all, and it's not even up and going yet, and we don't know who their clients are going to be. Are they going to be unfunded people, or is she just going to be serving those who want to have a natural childbirth outside of the hospital and can pay for that? We don't know what her target audience is going to be, and maybe what kind of, could we actually restrict our funding to them to say that, this is to go to needy, unfunded populations, tandem, but ask them first and come back, and we could be considering that information from them rather than just blue skying it.
Yeah, I agree with you, Mark, though I think it's a little dangerous to ask people what they want.
Yeah, and I understand that, but maybe there's a way to, kind of couch that and say, what's new that is underfunded for your organization.
Yeah, it would be nice to know of the population that the birthing center is seeing, how many of the people are coming and not able to pay, or.
Right.
Yeah.
That money goes to a very specific population, being those who are not eligible for Medicaid, which pays for like 60% of childbirths,
Yeah.
So.
And if there's, and I, as much as I like Volunteers in Medicine and now HealthNet, HealthNet's a very large organization, and they're well endowed as well.
Yeah.
And so I'm not saying we shouldn't give them the money that we normally do, and they do use it for those.
Yeah, I think the money should follow the clients.
Yeah.
In this case.
Yeah.
And if the birthing center is going to be seeing these clients and taking some of that away from HealthNet, then the money should follow where the clients are.
And I do know that, just in talking with Hattie a little bit from Tandem, that they do intend to have some funding or scholarship, some ways to help people who need that help. So they clearly they're going to start, I think, with Medicaid in terms of their insurance billing, and then they will add other insurance to that.
So I think what we need to know from them is when they are entertaining, seeing those clients.
Can I ask a question? Hello, can you hear me?
Yes.
Hi. Hey, Penny, is there a chance that we could get like a summary of all of the various agencies that we support, and then how much we've been funding them and what we've been funding them for? Just kind of like an annual report, in the sense that will help us kind of, one, prioritize the health boards. We can prioritize where we want our funds, but also two, kind of, we'll have it all in one place where we get to see who we're funding and what we're funding. And then maybe like the year before, what we were giving them the year before, if we increased it, decreased it, I don't know. Something, what I mean? Just a summary, because I think that would be helpful for us to see it all in one place.
Yeah, there's only three, right?
There's only three.
There's really only three. You have a contract.
Well, that's not that hard then. When Mark was talking, I thought are we getting more, or are we getting?
Maybe, but
okay.
You have, so kind of where I was.
Three's manageable.
We have a contract with IU Health, Community Health, for public health nurses. So we have a contract that lays out what to do, right? And that was my question in terms of last year. We increased it 2%. We have went years where we didn't give them much of any increase at all. A few years ago, we made a substantial increase to that. Now, in the last couple of years, we've had a lot of extra money come through COVID. We've also had a lot of extra expenses, right? So that, because it is a set contract with what we expect from them, doesn't change a lot every year. And I don't know, I'm not even saying that you have to do an exact percentage each year, but you could start with, our plan is to do 1% or 2%, and then you'll evaluate it from there. Maybe it's more or less depending on what's going on. I still agree that, we always tell people we're coming into budgets, right? So if we have a contract and something needs to change, we can do that. But we can send you that amount. The annual report has this information in it, but I don't know that it has our contracted amounts. That's not in the annual report, but we can certainly send that to you. Then Indiana Recovery Alliance, we have a 2-year contract with, and because that's a 2-year contract, and we didn't get a specific request and need for additional, I would say look at increasing that when we renew that contract.
Okay.
Although
When is that?
the contract will go through 2023. So
Next year.
in 3, we'll be looking at a
So
renewal
we do the 2023 budgets, when we look at that.
when you would do the 2024 budget.
And
2024
ARPA money,
Right,
ARPA
okay.
money cannot be used for personnel, right? I mean, can we, I mean, because I mean, when people, you know, when we know what they're gonna say, I mean, if we opened up the table and said, what do you need? Bodies is always gonna be a big
Yeah.
response, but are we limited in how we can fund our partners? Or can we say, well, you know, we can give you enough for one, you know, full-time or, you know, 2 part-time people?
Well, I'm not sure that I fully follow the question, except
Can the money be used for people rather than equipment and programming?
okay, we're not talking about ARPA money here, right? We're just talking about the health fund or the trust account or the local health maintenance funds.
Okay,
So if somebody wanted ARPA funds, they'd have to be going through the commissioners.
the
and
commissioners,
council.
that's right. That's been
Yeah,
a while,
not the
sorry.
health department, no.
And we just typically don't fund people, is that?
Well, yeah, I mean, we've got a tax levy, our tax levy and our fees do not cover our full budget.
Okay,
So we
right,
rely on currently our cash balance, all those things together. And then hope that if we need additional funds, because our cash balance is less, that our tax levy would be increased, right?
okay, right.
So, but that is all in the end in council's hands. So as a board, you can say, this is what we want in our budget, and then we'll go take that to council and request it. But there are some things that some different agencies that it might make sense that they just go directly to commissioners or somebody else for, and there are other agencies that do that, that the commissioners fund or those kinds of things.
Outside of our budget.
Yes. I think, see, we use local health maintenance funds for the prenatal care because they're local health maintenance funds, they're state funds, it's maternal and child health. And that was a gap and a need that the health department saw, right? In people who didn't have coverage that were falling through the gaps. So that was my note in here. Maybe you want to continue to fund money to Health Net, but maybe in addition, you want to spend some of the cash balance in local health maintenance to supply another entity. Now, Tandem hasn't opened yet. They won't know who they're serving. You know, we won't have that information right away. But I think it is, I mention it because I think it's something to keep on the radar. And I think it could be something that you say, we want to put money aside in our budget. So if they come to us with a need, maybe we're in a position to give that. Or if they don't, but Health Net had a surge of people, we could give them additional funds.
Yeah.
I like that approach with Tandem because they're sort of a startup right now. And, you know, we're not like angel investors or whatever, you know, we fund the actual operation and it would be nice to, you know, have them up and going. But maybe just put some money in the budget, but don't go to them and say, you know, you got it. But the question is the amount, you know, just the amount.
And this is a number that fluctuates because of the need. So,
yep.
So I don't have any issues with having a little extra in the budget for that because this is a need this is a good investment in health.
Yep.
One of our better ones.
Mm-hmm.
I have a question about the Indiana Local Health Department Trust account.
Yeah.
I thought that money was drying up.
The local health maintenance fund has good cash back. Yeah, so far the money is still coming in.
So it's to the trust fund, because I know that it was like for 20 years, and 20 years is up.
Yeah. Nobody knows when that might go away, and it could. And that's one of those things to keep again in the back of your mind,
Stock market's
Right.
down, so maybe the fund is down.
Yeah.
it's population based, so we get a specific amount each month or each year. And then it, you know, the length of time I've been here, I saw 1 year, we saw a change in the trust account. And then it went back the very next year. So it's some weird, and they're different. They're not
Okay.
the same
And
population.
so from that account, it basically covers the tobacco cessation and medical reserve corps, right?
The trust account does,
Yeah.
it has a smaller, the trust account has a much smaller cash balance
Right.
because we get less money as well.
So does the money coming in the past cover the cost of the personnel on that?
No, the past few years, we've been using cash balance to cover that. If that went away next year, if they said, oh, you're not getting any more of that, then there would be enough funds in that cash balance to carry it, depending on what salaries did, several more years,
Okay.
but maybe 3, 4.
And that was my next question, is how
Yeah.
much cash balance is there? So we have some time to go to plan B if that
Yes.
stops being funded.
Yes.
Okay, that was my question.
Yeah.
All right.
And then the local health maintenance fund has a much heftier cash balance.
Is there anything else that supports that you think that, you've mentioned 2 more vehicles?
Yeah, we bought we replaced 3 trucks and the staff are just thrilled with that. They took the old vehicles to auction and I think they got around $7,000 for them. I haven't seen the actual amount yet. So that's, you know, that's an approximation. But we are adding some environmental health staff, and in the past, some of our food staff, they weren't interested in a vehicle, but there's some interest now and maybe even having one available. So my suggestion would be to consider 2 new vehicles. And then we have the car, so we could shift that around and I think have coverage. I wouldn't get more than that right away. But local health maintenance has funded our fleet of vehicles, so they're not a burden on the county
Right.
because we're paying for them.
And who pays for the gas for these vehicles?
We do.
And where's that, which budget is that in?
That, well, it depends. If they're a grant, they might have mileage in their grant.
Yeah.
If not, it's coming out of the health fund. But if they're driving their own vehicle, we're paying them mileage at the state rate for mileage reimbursement.
So that's something we might need to increase in our budget?
We may want to, yes, increase the amount of money in that line, yes. The county, the state sets the mileage rate and the county follows the state reimbursement
Yeah,
rate.
but we pay for gas for the vehicles.
Yes,
So-
that would be an example of, oh my gosh, you know, yeah, the last 3 years, we haven't spent all of our money. Well, we've not been out in the field near as much and now gas prices
Yeah.
have doubled.
So
So
yeah,
that would be an
that's something
example.
that you might want to do. That's
Right.
a thought I had about the budget. I was
Yes.
looking at these trucks. Trucks take a lot of gas.
I mean, we do get pretty efficient trucks now and that kind of thing, but they do use a lot of
They
gas.
still use gas.
That's it. Yep.
And you mentioned maybe the temporary positions permanent.
Yes, I think that temporary environmental health specialist position, we've shown the need and the use for that for the past 2 years. I think that would be a very easy ask to make that permanent.
Seems fair.
So I would do that. We're hope to be filling this 1 vacant part-time position that we have soon. But I think the other thing, and this may not be a 2023, but it might again be something on the back burner. If we're not able to continually fill those part-time positions, then it may make more sense to try to make a full-time position that we might be able to fill, even if it's more of a support role.
And what roles would those be? You mentioned environmental health. And then what would our other like part-time ones
The part-time ones that I would be saying kind of pooling together. So we have a lot of options for part-time, but we have a regular part-time that, so think that soil scientist that we kind of moved down, right? That went away. Then we had kind of a soil science assistant that we call them. So that's the position that we're looking at. So it's really kind of a support position, mainly for wastewater, right? To record searches, GIS information, those kinds of things. But we typically have a summer person in pools. We have had a part-time person in foods at various times. So that's what I'm saying is at some point, if we can't maintain those, they typically tend to be students, then it could make sense to make it a full-time and keep it filled. Now, council will say full-time people cost a lot more, right? And so you have to think about that. But if you're not able to fill them and you need those spots, then it might make sense to ask for a full-time.
And then I know the council sets the payroll.
Yes.
Basically, is there any way to, I mean, 'cause this is a bad year for people.
Yeah, and they just did a market adjustment, you know, recently. So they're deciding, I haven't heard what they're talking about in terms of salary increases for next year or not.
We don't have any control over
Yeah.
that.
No,
No.
council sets all that. Yeah.
That's what I
Have we
thought.
ever utilized like a soil scientist like under contract?
We did, and well, we had them as an employee. The problem is there aren't very many soil scientists anyway.
Right,
And they
which is
take a
kind of
lot-
why I wondered about, like, if we put them under a contract, you know.
We can't afford them, quite
Oh.
frankly. They make a whole lot more money privately than they do. And when the last person we had who was part-time and came in and at a time when they were able to get insurance. And so without benefits, they wouldn't have been in that part-time position either. That was the key. And we didn't get any applicants. There's maybe 65 soil scientists in the state. So they are hard to come by anyway. But they make a lot more money on their own than they do.
I should go back to school.
Yeah.
Are we gonna need them as much with the change in the legislation regarding the septic?
Well, their information is needed no matter what. But soil scientists will be one of the entities that can kind of override what we say.
So, but
If
I'm
an
not sure that,
engineer,
I'm not sure that I understand then why would we want one if somebody else can just hire one?
yeah, and that we
overrule
had
it?
all of this,
Yeah.
when we had all of this discussion before too, why really did we need to have soil scientists on staff when you could get that service and we could put those funds to other things?
And especially now, I mean, that's Kay's point, you know, but somebody could just come along and all they need is somebody that says that it can, and that's about it.
The right people provide the right information and say they can do it.
Yes.
Oh.
We should just try not to smile when we say that.
Did we cover pretty much everything on your list here?
I think,
I think we did.
like I said,
Not
currently,
necessarily in this order.
yeah, Jamie
Yeah.
just was able to put together the last several years and kind of where we are, what we've spent so far this year. So we can kind of do some forecasting and look at that. The things that popped out to me, really, there were only 2 lines when I looked at them so far that seemed off. One is our Vax Care. And that is we get, that's a third-party billing. So they do the billing for vaccinations at the clinic. And then when they bill and get insurance reimbursement, that comes through us. And then 80% of that goes back to the clinic. We keep 20, which it hasn't traditionally been very much at all, right? We started out and we said, well, we'll put 10,000 in there. And we have to have that line because that's what we pay the clinic their portion from. We kept lowering it because we weren't using it all. Well, now they are billing Medicaid. And so we're
Makes a big
starting to
difference.
see more money. So that's a line that we'll want to increase. And then we're spending more in our assessment line, but that's really because we're doing this after action report because council declined our request to pay for it and told us to pay for it out of our budget. So we're spending it out of that assessment line. So
Okay.
I do think we did get, finally got reimbursement. The state did billing. So the good thing about that vaccine scheduling system, SOTEC, is the state used that to bill insurance for that administrative fee on our behalf. So we are, and we're kind of doing the same thing we do with that VaxCare. We are able to then reimburse Indiana University a little over $300,000 for the vaccines that they gave at their public site, and over $200,000 to our public health clinic. Now, that won't be continuing, right? That's kind of one-time reimbursement funds. But we will, because we have to process all that, we hold some of that money back, kind of our fee for doing that. And I think that we could keep our assessment and accreditation fees at that $10,000 level, but maybe use that vaccine money, that reimbursement money we got, to cover the cost of applying for accreditation. So that's one thought for using those funds.
When is that, Penny, the application?
Well, everybody will have to see, we've got the CHA, we've working on the CHIP, we've got the strategic plan.
Just for the public's sake, can you explain, can you just say what CHIP and CHIP are?
We've done, we're working on the community health improvement plans. Thank you.
There we go. Thank you.
Got this plan done. And we've got lots of other pieces and parts, but again, seems like every time we make headway, something happens that pushes us back down. This is where I think having those two new manager positions will really position us better, because we'll have the ability to really hone in on that. So
stay focused.
Our strategic plan actually set for applying for accreditation. I think it's 2024, might be 2023. So Lori, it's coming up.
So wouldn't it be appropriate to ask staff for a report on how going towards accreditation in terms of just what else we have to do?
Well, it's always kind of in our agenda to have something on one of those things. So, you know, Kathy spearheads the accreditation, so we can tell her we want more information on progress that's being made.
Yeah, a quick report would be nice in next meeting, but because next meeting's really budget, that's gonna take a lot of time. So that's probably not the best meeting to try to discuss anything in great detail. Maybe like, you know, one of the upcoming meetings.
Right. Documentation, and it's really not so much the documentation as gathering all the documentation.
Right.
And then implementing some of the different plans. So we've got a lot of plans like workforce development, those kinds of things. But again, sort of getting them implemented well and being able to document that implementation has been the bigger struggle. So we really, I think, are in a pretty good spot, but there's still lots of work to do.
And I have a question, has nothing to do with what we're talking about, but it kind of does. It's about personnel in terms of people, finding people to fill these spots. Is that because people aren't getting trained in that area, or is that because county pays so badly? You know, what was the issue?
Well, everybody's having trouble filling vacancies. I mean, Indiana University has a ton of vacancies. The state has so competition's high. And, you know, I'll tell you, I was at a chamber discussion and I was on a panel and Catalent was there. And, you know, I'm like, well, thank you for paying very well and taking, you know, and I am glad that we have people in the community that pay very well. But it affects, you know, our restaurants and other places. It affects every other business.
Is there any kind of associate's degree, like maybe that you could try to work with Ivy Tech to train
Well,
more
I will
people?
tell you what, I don't think so, but I will tell you this, Indiana University is applying for a grant, a SAMHSA grant that will actually pay for education, and part of it, and there's kind of different pieces. So it's to try to get people into public health, but also to take health department staff. So maybe you have health department staff who really don't have a public health degree, but that they could get their degree online in public health and the cost be covered. So because the cost is the prohibitive, time, but cost is as much a
Well,
prohibitor
that's
as
why I was wondering if
anything.
there's any sort of associate degree that could work. Because Ivy Tech costs half as much as I use.
Right.
And,
Yeah.
and they also have they can do things quickly over there. So.
Yeah, I will say there are a lot of things that, you look for the softer skills, because, there are a lot of things that we might be able to teach somebody to, like, these are the tasks. We can teach you to do those. If you have these other skills, we can teach you that. There is a public health and you certification people can get. So that's part of our training. So especially people outside of public health realm, to try to get them so that they have that for public health to come in.
Well, and I think any extra education and training is paramount, because the staff gets motivated about implementing new processes, new theories, the laws are always changing and we have to accommodate. So I think that's fabulous. I'm all for it. And if, we can encourage our full-time staff to go to school, then I think we should. I think that's fabulous. Absolutely. Because we'll just benefit as a community from their energy, from their new ideas. I remember how I was much more useful back when I was getting my master's degree. I had all kinds of ideas. I was going to change Bloomington and Monroe County, and we want that kind of enthusiasm. And if you can keep it on your staff, even better. So I applaud that one. You go for that.
So yeah, if there are any specifics, feel free to reach out and let me know, and we'll be working on it and try to get something to you early and just send that so that you get it. It doesn't get,
Yes.
But if we have a meeting coming up and you haven't gotten something 48 hours before, reach out.
Well, that problem is I don't look at it until right before, because some may stick a little bit.
Well, I think I thought some folks maybe, and this is what I thought about you. Well, the reminder went out, and I bet when she got the reminder, she said, I got the reminder, but I don't have a packet. So,
yeah, when I saw the agenda, I just figured that was a packet. I didn't need to look at it. Until, So, good. Any other budget issues you want to talk about? Anybody? Hearing none. Any other board member comments? Questions? Anything? Everybody's quiet. I like that. So our next board meeting is July 14th.
Yes.
Right here.
Yep.
In there.
And that is one thing that I'm going to have to check, because when you're voting on the budget, I don't think you can do it via Zoom. So we may be able to have a hybrid meeting so the public can still join, but you as a board member will have to be
We see
in
the
present.
quorum vote, right? So if there's 4 people here, then we can do it.
Yes.
So we need to have 4 people here at the next meeting.
Yeah.
I should be here.
Yeah. You always need 4 people here. Yeah.
Okay.
So,
And are you going to be here?
yes, I will be here.
Your last.
Lori and I will be here.
Oh, great.
Won't we, Lori?
Looking forward to it.
We're not sure now.
Okay, so we have a motion to adjourn.
So moved.
Need a second? Second. Okay. Steve K. The meeting's good. Thanks for coming, everybody.
Thank you.